Hello everyone. In this lecture, I am going to deal with the very important tool which is being used nowadays, and as it is being recommended by World Health Organization to monitor the progress of labor and well-being of mother and fetus, is the Labor Care Guide. So yes, it is the revised and reviewed Partograph, because previously we used to monitor on modified WHO Partogram, but nowadays it is being revised. So what is new in this labor care guide, that we'll discuss in this video. So as I have dealt with its different types previously, so I made a video on that, what is Partogram, and the Partogram firstly devised by Friedman in 1954, and in that Partograph the action and alert line was introduced by Philpott and Castle in 1972, and later on composite Partograph was introduced by WHO in 1994, where latent phase was being monitored previously, and after that in 2007 January, Walliso introduces modified WHO Partogram, and in that the latent phase was removed, and the action alert line was being plotted from 4 cm onwards. So the all details are being discussed in the previous video, and the link of the that video is given in description box below, so you can go through with previous different type of Partograph. There I have mentioned how we can do plotting on them. But nowadays in 2018, the WHO recommended new guideline to plot all the labor progress and the well-being of mother and fetus, and this is to be done on labor care guide. So here in this lecture we'll discuss various aspects of labor care guide and how we can do plotting on this. So why there was a need of labor care guide? It was seen that the mother should receive a supportive care throughout labor progression, because it is a fundamental right for every mother, and as she gone through with many fear and anxiety, once she receive a support, a care and pain relief measures, she feel better and experience a positive experience with childbirth. So to ensure that, we must provide supportive care by using this tool. Even though many skilled birth attendants who are practicing unnecessary intervention, that can be prevented by using this tool. And if while monitoring or documenting the progression of labor or the well-being of mother and fetus, along with if anyone found that some abnormalities are there, some complications are being arise, then these abnormal alert references are being highlighted by circle, and that to be care of, and necessary action could be taken. Now let's see what 3 W's are there in labor care guide, that is whom, where and when. So first is whom all can guided by this labor care guide, that is all mothers at term, whether they are at low risk or at high risk, can be monitored through this tool. Because high risk mothers can easily be monitored through this tool, and the findings can be highlighted, but they required additional supportive care as well. And the second W is, that is when to be guide used. So once the women enter into the active phase of first stage of labor, because here the definition is modified, and here the active phase begin at the 5 cm of dilatation. So once the women have 5 cm dilatation, thereafter we can monitor the mother through this tool. And the third W is where. So this tool can be used in all the health settings, whether they are primary, secondary or tertiary, because what happen if the mother is monitoring at the low level or at a primary level, and suddenly the complication arises, then these findings can be highlighted and immediately the action can be taken off, and she should be immediately referred to the higher center. So ideally this tool should be used in every setting of health. So these are the 3 W's, that is on whom we can use this tool, where to be used and when to be used. Now before we proceed with the plotting on this graph, just look on some similarities and differences in the previous older Partogram, that is modified WHO, and in this latest one, that is LCG Labour Care Guide. So if we talk about similarities, then both the graphical presentation have the recording of progression of labor, well-being of mother and fetus, or even though some clinical parameters can be monitored through this both graph, like fetal heart rate was being monitored, and even though they both have the recording of blood pressure and pulse rate, or even urine analysis of mother. So these are the similarities between both the Partogram. And now let's see what are the differences between modified and LCG. So in modified, if you see, the alert line, or you can say the active phase of first stage of labor, begins at 4 cm dilatation. But here the plotting begins from 5 cm onwards. The dilatation rate was fixed, that is 1 cm should be dilated in every 1 hour, that is 1 cm per hour dilatation rate was fixed. But here in this LCG, there is no fixed criteria, that is in every hour the 1 cm or 2 cm cervix should be dilated, because nowadays it is completely based on evidence, because it was seen even in mother who have the slower dilatation rate, they also have better vaginal delivery outcomes. So by seeing this, it was now being changed, and there is no fixed rate of cervical dilatation in every hour. This is now being changed in LCG. And if you see in modified, there is no plotting on labor progression during second stage of labor. But here in LCG, we are even though monitoring the second stage of labor as well, till the fetus delivers out. And even though if we talk about the uterine contraction, then in modified, the strength, duration and frequency, all 3 things are being monitored. And nowadays in LCG, only duration and frequency of contraction are being monitored in every 10 minutes. The strength, that is previously we are using the boxes, that is the mild by dotted, moderate are being plotted as a slanting line, and the severe contractions are being plotted by the dark boxes. So this is how we are not plotting on LCG. So only duration and frequency, how many times the contractions are being appeared in 10-minute period, and for what period the contraction lasts for about. These 2 things are only we are monitoring in this LCG. Even though on modified there was 2 lines, alert and action line, but here in this, as there is no fixed cervical dilatation rate, so thereby there is no alert and action line on this LCG. In modified, suppose if any complication happens, that abnormal deviation can only be identified by monitoring the line that is being plotted in between the alert action line, or if the plotting goes beyond action line. That is when we are monitoring or recording the cervical dilatation on alert and action line, that deviation is being found to be abnormal if any complication happen. And rest of the finding, if goes abnormal or any deviation found, then no action would be taken off. But here in LCG, what happened? We are assessing the mother, and even though we are recording these all findings, and at any point if we found that the findings are not normal and they comes in alert column, the findings are matched to the alert column, that is the early warning signs, then we need to take action and appropriate intervention can be planned off through this LCG. So these are the basic differences between the modified WHO and the LCG. Now next we'll talk about how many components and what all structures the LCG have. So in this LCG there are 7 components. The section 1 is dealing with the identification data of mother and the characteristics of labor, and the second section is being dealing with the supportive care, and the third section is dealt with the care of baby, Fourth section is caring of mother. Fifth section is showing the progression of labor. Sixth section is dealing with the medication which are being used during labor progression. And the seventh section is dealing with the assessment and the planning section, that is shared decision planning with the mother and companions. So these are the 7 components and the part of graphical recording on this LCG. So before we start with the plotting system, every skilled birth attendants, that is whether it is midwives, doctors, obstetricians or even though nurses, they should be take care of that every column should be filled by 4 things. Because if you are practicing these 4 things systematically, then the mother is being, or even though the baby and progression of labor is being monitored very carefully. That is, the 4 things are ARCP. A, assessment, R, record, C, check and P, plan. So first you have to assess the mother, baby or progression of labor, anything. Then we have to record this finding. That is, we have to document, write in that column. Third thing is we have to check, because here in this LCG there is an alert column. In every finding, in every clinical parameter, there is an alert column. That is, this is the reference, that is the early warning sign. By keeping this alert, you have to check whether your findings, whatever you have recorded, is normal or abnormal. So suppose if you found this finding is not normal or it comes under alert and early warning sign, then you have to make a circle with a red color. That notified very easily and accordingly you have to plan. So these are the 4 criteria while you are filling the LCG labor care guide. That is, you have to assess the condition first, then you have to record, thirdly you have to check with the early signs, and fourthly you have to plan. Now we will see how we can plot on this LCG on this all 7 sections. So the first section you can see here, that is the identification data of mother and the characteristics of labor. So there you can see the first is name. Here you have to write the full name of mother, and the second thing is the parity, that is in numerical way you have to write at how many times the mother have the previous viable birth, so that number you have to write. And the labor onset, usually in normal labor, the onset is usually spontaneous. Spontaneously the labor start, the true labor pain start. But suppose if any induced labor is there, where artificial rupture of membrane is being done, or even though some balloon catheter are manually being inserted to separate the fetal membrane from decidua, or even though some drugs are being used like oxytocin or prostaglandin, so in such condition there you can write induced. Otherwise, in a normal cases where the mother have pain spontaneously, then you can write spontaneous. The next is active labor diagnosis date. There we can write when the mother enters into the active phase of labor, when the cervical dilatation is being more than 5 centimeters. So that date in day, month and year format you have to write. Next is the ruptured membrane. Here you have to write the date. Suppose if the mother came with a ruptured membrane, then you can write the date, and this can be, we can ask through mother or even through companion, whatever the person who came with the mother, from them we can ask this detail. And suppose if they are not knowing when that membrane get ruptured, that date and time they are not knowing, then we can write U, that is unknown. And next is the risk factors. It means if the mother had the previous history or the current history of any risk, any medical and obstetrical risk, any preeclampsia, previous abortion, stillborn history, elderly primigravate mother, any adults in pregnancy, preterm labor, so any risk to her health, chronic hypertension, that all risk we can mention here, whether it is from the past pregnancy or whether she is running through the current pregnancy. So all risk factors we can write it here. Now here, before start with the section second, there we can see very important that is the time and hour. Here each column, the big one column is equal to 1 hour, and at every column there the hour is also written 1, 2, 3, 4 respectively. So the time, the first column represent when does the mother enter into the active phase, that is at the 5 centimeter dilatation. There only we can write this timing. Suppose the mother came at 6 a.m. morning and she had only 1 or 2 centimeter dilatation. In such we can't write it here. But suppose once by per-vaginal examination we found that she had 5 centimeter dilatation at 10, then we can write the timing 10 in the first column. So whenever the active phase begin in the mother, that is the 5 centimeter dilatation, that time we have to write in the first column. And respectively each column is to be counted as a 1 hour. So if you are writing 10 in first column, then 11, then 12, and then 13, or either you can write 1 p.m. So this is how you have to write the time. So the next section is the section 2nd, that deals with the supportive care. That is the fundamental right for every mother to receive the care throughout her pregnancy by the family member or through midwives or any of the health personals. So what all supportive care we can provide by this guide are mentioning here, that is the companion, pain relief, oral fluid and the posture. So for companion there are the 3 abbreviations Y, N and D. Y means yes, N means no and D means denying. So if at the time of admission or at the time of active phase of labor, when you are plotting in the first column, and if you are writing that she is accompanied with the family member or her husband is there with her, then you can write Y, that is some companion is there. And if she denies that she don't want any companion, then you can write D. And if no companion is there but she wants that someone should stay with her, then in such condition you can write N, that is at present there is no companion. So N you can write and make it circle because it comes under alert column. It means because the basic aim behind this tool is to provide support either through her family member itself. So if she wants that any partner should stay with her, then we can plan and we can call for the companion. So this is how we can make a circle and plan and provide the companionship. And the next is pain relief, and again in this also we can have abbreviations Y, N and D, yes, no and denying. If she is not receiving at present any pain relieving method, then we can write N and make it circle, and even later on we can provide her pain relieving method like any analgesics, epidural analgesics at a lower concentration like epidural if she prefers, even though any pharmacological opioid analgesics like fentanyl, diamorphine or pethidine, even we can administer to the mother if she prefers. Or even if she don't want to go with the pharmacological method and she want non-pharmacological methods like breathing techniques, muscle relaxing techniques, some music therapy, some hot packs, or even she wants some massage from her companion, then this can be planned and can be given to the mother. So first we have to assess whether she is receiving, then we have to record the finding, what is the current status, and then we can check with the alert column, and lastly we have to plan if she want, and that reference, if that finding is similar to the alert columns reference, then we can plan accordingly. So this is how we have to go with this finding. And the next is the oral fluid. Here also we can write Y, N or D, that is yes. If she is taking some fluid, you can write Y, yes. And if she is not taking from prolonged time, then you can write N, no. And if she denies to take, then you can write D. So if comes under N, that is she is not taking, then according to WHO we can advise or plan the mother to take more fluid in her diet, and even though she can take light diet, because the labor process requires energy, and if she remain on fasting, then her energy will also be declined. So to boost up all the energy, we can ask the mother to take drinks, juices, light chips of water, sips of water, even though she can take. So because if she is not taking orally, then we have to infuse the IV fluids, and that is not good, because if we infuse IV, then she will remain on bed, and more she will lie on bed, the less mobile she will be, and that may delay the labor progression. So this is how we can advise to take more fluid to the mother. And the next is the posture. Here you can write SP or MO. So MO means she is mobile, that is she is moving, ambulating, roaming around here and there, and SP means supine, it means she is lying on bed. So suppose if she is entering in active phase and you are recording SP, that is on bed, then we can encourage the mother, if she is not able to mobile, then even though she can lie in left lateral position, in squatting and kneeling position, so she can change the position, and ask her to mobile as much as she can. So more she mobile, more the fetus will descend. So this is how we can encourage and change the posture of mother. So these are the 4 things, that is the companion, pain relief, oral fluid and posture, that comes under supportive care, and that should be given to the mother throughout her labor. Now next, third section is dealing with the care of baby, where the first thing is baseline fetal heart rate. So we know that the baseline fetal heart rate is ranging from 110 to 160 beats per minute. So here in this alert column, it is mentioned less than 110 beats per minute or more than equal to 160 beats per minute. It means if the finding goes less than that and more than that, it comes under abnormal finding or on alert. So we have to record the data in a numerical way, that is even whatever the fetal heart rate is, we have to auscultate and record in a beats per minute. So first important thing is we have to auscultate during uterine contraction, is very important, for at least 1 minute, and once the contraction is being passed, after that 30 seconds till we have to record the FHR. And for recording the FHR, we can use even Pinard stethoscope, or either we can use the Doppler USG. But cardiotocography is not being recommended by WHO, that we should record FHR on CTG is not recommended. So next category is the fetal deceleration. There in alert there is written L. So here the abbreviations, non-numerical value that we can use are the N for no deceleration, E for early deceleration, L for late deceleration, V for variable deceleration. So what is deceleration? Deceleration means slowing down of fetal heart rate. So we have to record the fetal heart rate for at least for 1 minute when the contractions are there. So once the woman have uterine contraction, at that time we have to record the fetal heart rate. So during contraction, if the fetal heart rate doesn't slow down, then there is no deceleration. But at the time of uterine contraction, when the contractions are beginning, reaching at peak and ending, at the same time when the fetal heart rate as well coincide with the uterine contraction by onset, nadir and recovery, if both the findings are coincides, that is the peak of contraction and the nadir, that is lowest point of the fetal heart rate, is at the same time, that shows the early deceleration. So this is mostly because of the compression of fetal head, and that stimulates the vagus nerve and thereby the flow will be reduced. But once the contraction are being passed, the fetal heart rate also recovers to its previous baseline. So this is called early deceleration. If we are finding early deceleration, then we can write E. But suppose once the contractions are being passed, then also the fetal heart rate still slowing down continuously, it means the fetal heart rate after passing contraction as well slowing continuously, we can monitor it as late deceleration. So this is mostly because of the placental insufficiency, the flow is not proper, uterine contractions are more stimulated. So because of that, the late deceleration could be there. And the other deceleration is the variable deceleration, where there is an intermittent periodic slowing down of fetal heart rate could be seen, and which is very fast in onset and fast in recovery, and that is not at all coincide with the uterine contractions duration or frequency and anything. So thereby it is variable, it varies a lot, it change a lot. So mostly it is seen that because of the cord compression, when the umbilical cord is compressed by the fetal presenting part, thereby the flow is not that much proper. That's how the fetal heart rate can vary. So this is called variable deceleration. So on the basis of that, we can write it here: no, N, L, E or V. So the alert is L, that is late deceleration. So once the contraction is passed over, if the fetal heart rate is not returning to its normal baseline, then we have to record as an early danger sign and make it a circle. So we can plan accordingly, and even we can advise the mother to lie in left lateral position, and even she can mobile, and even though we can plan more, and even fetal heart rate is not returning back to normal after continuously monitoring, even though, then we can call upon the senior person or we can monitor very closely again. So here the fetal heart rate, the fetal baseline heart rate and the fetal deceleration are monitoring in every 30 minutes. So here in this column you can see the one bigger column is divided into two. So one column I have said that is equal to 1 hour. So it is divided into two. It means in every 30 minutes we have to record the fetal heart rate and its deceleration by using stethoscope or even Doppler USG. So next is the amniotic fluid, and we know that till first stage, especially in primary gravid mother, once the cervix get full dilated, the membrane remain intact. So suppose if the membrane remain intact, is being not ruptured, then we can write it here I, intact. And suppose if it get ruptured, then we can see or check the color of amniotic fluid, and if it is clear, then we can write C. But here, if the color of amniotic fluid is stained with the meconium, this also varies. Somehow it is not that much significant, some with medium consistency, or somehow it is highly stained with the meconium. That's how we can write 1 plus 2 plus 3 plus. Or B means blood stain. It means it can be seen if the placenta is low lying. It means the placenta previa is there, vasa previa is there. Even if placenta gets separated in abruptio placenta, or even if uterine rupture happens, in such condition the fluid can be contaminated with the blood. So it can be stained with the blood. So there we can write B. So if M3 plus or B is written, then we have to call upon the seniors. The next is the fetal positioning, and here the alert is the P and T, because we know as soon the fetus descends more deeply, the fetus change its position. Initially it is lying in transverse, but later on with the progression of labor it turns anteriorly. So if you are writing A means anterior, P is posterior, T is transverse. So after progression of labor, still if the fetus lie in transverse and posterior itself and it is not rotating anteriorly, it means this is an early danger sign. So we can record and circle it and call upon the seniors. Next is the caput. Caput is the swelling over the scalp because of the compression of fetal head. So suppose if the head is compressing more and there is swelling is found on the scalp area while we are performing pervaginal examination, on the basis of that, if there is 3 plus, it means highly the scalp bones are overlapping and they are too much compressed, then the scalp can be more bulged out, and this caput succedaneum can be written as 3+. So if this warning sign is being found, then we can call for senior. Next is the molding. So molding is again the overlapping of sutures, because it also can be written as an 0, +1, +2, +3. So 0 means the sutures are wide apart, there is a gap, and 1+ means the bones are come closer and they are not overlapping, and +2 means the bones are overlapping to each other, but while we are performing pervaginal examination and if we are generating a pressure, they get separated, they are reducible. But +3 means they are highly compressed and overlap to each other, that after giving some pressure as well, they are not reducible. That is the +3 molding. So usually from 0 to +2 there are the normal findings. Somehow the molding takes place to allow the fetal head to be passed through this birth canal, but suppose if goes more than 3+, that it denotes that the fetus is highly compromising, the labor is more obstructed, the cervix or the pelvis is not that much favorable, so we can call for senior. So in this section third, the amniotic fluid, the caput, molding and the fetal position, these all findings are we getting through the pervaginal examination. So according to WHO, the pervaginal examination should be done 4 hourly unless it is required more. So unnecessarily hourly PV examination is not recommended by WHO. If the findings are normal, under normal criteria, then we can shift this finding and we can repeat this finding after 4 hours. Now next, fourth section is dealing with the general condition of mother. So first, here it is written the pulse, and in alert it was written less than 60 is dangerous and more than equal to 120 is dangerous. So for at least 1 minute we have to palpate the pulse rate, and suppose if the pulse rate is more, then this can be indicative of that the mother is having more pain, or she is dehydrated, or even though she had fever. So this can be the signs of raising the pulse rate, or even though if it is dropping down, then maybe there is a hemorrhagic shock. So by the pulse rate, even though we can identify some risk factors. So we have to record for at least 1 minute, and here in a numerical way we have to write per minute, the pulse rate per minute, beats per minute. The next is the systolic blood pressure, and the alert is less than 80 and more than equal to 140. So here we have to write in a numerical way in mm of Hg, and suppose if the blood pressure drops down, then it can indicate the features of shock, and if it goes more than that, then indicates the features of hypertension. So we have to record by allowing the mother to sit down on a place, and then we have to record. So systolic and diastolic blood pressure should be monitored by making the mother to sit down and then record it. In similar way, the diastolic pressure, the alert is more than equal to 90 mm of Hg. So if it goes more than that, then it is indicating of high blood pressure, hypertension. Next is the temperature, and this we have to record in a degree Celsius. So here we can see that the less than 35 and more than equal to 37.5 is the danger sign. So whatever we found through auxiliary temperature, we have to record for at least 1 minute, and in a numerical degree Celsius manner we have to write it here. Next is the urine analysis, and in this we have to record the presence of protein and acetone in urine. So through reagent strip we can ask the mother to void, and through reagent strip we can check for presence of protein and acetone. So here we can write in negative trace, that is in less amount present, and +1, +2, +3, or acetone even we can write +4. So here if you are writing there is no presence of protein and acetone, then you can write negative/negative. And if you are finding trace, then you can write trace/trace. So this is how we can write. So the presence of protein indicates the presence of preeclampsia in mother, even though undiagnosed cardiac or renal diseases could be there. And the presence of ketone indicates the undiagnosis of diabetes mellitus, or even though dehydration because of excessive loss through vomiting and diarrhea. So the values of these can be changed accordingly if there any condition is present. So this is how through reagent strip we can check for acetone and protein. Now next is the section 5th, and this deals with the progression of labor. So here you can see that is in first column, here the written is the contraction per 10 minutes. So for at least 10 minutes we have to check for uterine contraction by placing both hands on the abdomen and checking for its hardness. And in 10 minutes how many the uterus get contracted, less than 2 times or more than 5 times are the danger or early warning sign. So in numerical way you have to record, and again this column is divided into 2. It means you have to record in every 30 minutes. So here either you can write 3 contractions, 4 contractions, these are the normal one. But if less than 2, more than equal to 5, then it is danger signs. And in similar way, then the next thing is written here is the duration of contraction. It means while you are checking for uterine contraction, for how many times, for how many duration the contraction lasts for about. So if you are palpating the abdomen and the contraction lasts for about 40 seconds, 30 seconds, so this is how you have to write in a second. So here the alert is the less than 20 and more than 60. So these are the seconds. If contraction is less than 20, it means that contractions are not that much stronger, and more than 60, it means the uterus is more stimulated. So these are the alert, and if you find these alert sign, then we have to make a circle. So here you can write in a numerical way. And in next column you can see here, that is the cervix, that is the dilatation of cervix could be plotted here, and it should be write as a X. And as I mentioned previously that in active phase of first stage of labor, the dilatation begins from 5 centimeters. So that's why the lowest value here which is written here is 5. So here there is no fixed dilatation rate, that is in every 1 hour how many centimeters should be dilated, because it is completely based on evidence and it differs from mother to mother. Sometimes the mother have slower dilatation rate. It doesn't mean that the labor is not at that much pace and she is in a abnormal or complicated condition. So in every centimeter there is a alert column. It means here the reference lag period is given, that is if the 5 centimeter dilatation remain for more than 6 hours, it means there is an arrest. The cervical dilatation is not progressing. So in front of every cervical dilatation there is a lag period. It means if this R is lagged behind and the cervix is not dilated after that period as well, then we can say that the labor is not progressing appropriately. Okay, like in similar manner you can see here, suppose if the mother had 8 centimeter dilatation and the alert column is showing that is 2.5 hours. So after 2.5 hour as well, if the mother remain in a 8 centimeter itself, it shows that the labor is not progressing. So this is how we have to record. So here again the cervical dilatation, descent of head and the other PV findings what we have seen previously, these all should be done with a gloved hand and maintaining the aseptic technique, and this should not be done on an hourly basis. So suppose if you are finding normal values without any deviation, then you should repeat this PV examination after 4 hours only. Otherwise unnecessarily PV examination is not recommended by WHO. And below to that is the descent of fetal head, and to monitor that or to document that we have to plot O. So how we can assess the descent? By placing our 5 finger above the symphysis pubis. So through abdominal palpation or abdominal examination, we have to find out that how many fingers are palpable above the symphysis pubis. That shows the presenting part. So more the head will descend down in pelvic brim or deeply engaged in the pelvic brim, less fingers will be palpable above the symphysis pubis. So suppose if the 5 fingers are easily palpable above the symphysis pubis and we can estimate that it is the presenting part, then we have to write 5. So here in front of 5 you have to make O. So suppose only if you are finding 4 finger above the symphysis pubis, then you can plot O in front of 4. And here in this you can see there is no alert column for descent of head. So this is how you have to write O, that is how much fingers are palpable above. Next is the section 6, that is dealing with the medication, and here the 3 columns are there: oxytocin, medicines and IV fluids. So here also you can write yes if oxytocin is infusing, and for that, if oxytocin is infusing, then you have to write units per liter, and even though you have to mention drop per minute. So if you are infusing 1 unit, in how much ml of RL or NS, you have to write that, and at what drop per minute you are infusing. So this all detail should be written here. And suppose if the mother is not receiving any IV infusion of oxytocin, then you have to write N, that is no. In similar way, medicine, if suppose mother is taking any medicine orally or intramuscular at any route, so you have to mention the name of drug, dose and route of that drug. And if she is not taking, then we have to write N, no. And below to that is IV fluid. So according to WHO, there is no recommendation of IV fluid. So if she is not taking, if IV fluids are not infusing, then we have to write N. And if we are infusing, then we have to mention the name of IV fluids and their details. Because unnecessarily infusing the IV fluid restrict the female's mobility, and thereby the progression of labor also stops. So to avoid that and make the woman to more mobile, we will not infuse any IV fluids. Rather, we suggest the mother to take more fluid orally. So this is how we can write medication in respective column in every R. And the last column which shows the planning, the assessment, overall assessment and the planning section, that is called shared decision making. It means this column represents that whatever the finding we get through all these clinical features, we have to assess and record it. That is, suppose all the findings come under normal, okay, then we can write it here that there is a normal progression of labor, and this is our assessment. And plan is, that is, we are continuing monitoring the progression of labor. And lastly, we can write it here the initials or the signs. Suppose during assessment we found any abnormalities, or if we found or if we highlighted any abnormal finding, then we have to write it here that we assess that abnormal finding and we plan for this particular finding. So this is how we can write it here. Suppose at the time of labor she didn't have any companion and she want that her family member should stand with her, then we can assess here that she require companion, she require oral fluid, and in planning we can advise her husband to stand with her to support, and we can suggest some pain relieving technique even though. So this is how we can write it here. So shared decision, it means whatever we have assessed through all these columns, we have to discuss with the mother as well as with the companion, and we should share with the findings, and we can even though plan with them that we are planning this and you have to cooperate with this findings. So this is how the planning should be shared with the mother as well as with the companion. So this is how we have to plot in labor care guide in the active first stage of labor. But once all the findings are going through very easily and the cervical dilatation also reaches at the 10th centimeter without any further complication. Then the next on right side you can see that there is a second stage as well. So on time section you can monitor that in time the first stage, the recording, the plotting is what is given here is the 12, because in primary gravida the first stage lasts for 12 hours, and here the second stage hours are showing around 2 to 3 hours. It means at anyhow the second stage should not go beyond 3 hours. So you have to plot in this time limit only. So here in this LCG we are even though very closely monitoring the second stage of labor. So in this also we can write the time above here. Suppose you have written the time after full dilatation, whatever the time the woman enter into the second stage, so you can write it here, and below that what you can write it here, the companion, pain relief, oral fluid and posture. So whatever I have discussed previously you can continue with this second stage of labor itself. But here the baseline FHR and the fetal deceleration are more closely monitoring in second stage. So here the one column is divided into 4. It means you have to record the fetal heart rate in every 15 minutes in a beats per minute. So in a numerical way we have to write, and even though the fetal deceleration in form of L, E, N and V, we can write it here. And below that even the finding of mother we can write it here, the pulse, systolic and diastolic blood pressure, temperature and urine analysis, and contractions per 10 minutes and the duration of contraction also we have to record in every 15 minutes. So here we can write, even though one more column is given below, and there we have to write P, because once the cervix get dilated fully, the mother also start pushing down. She also put some effort for bearing down, and till the fetus completely expels out, she bears down vigorously, she push down. So we have to write P if she are putting some efforts. So we can write P for pushing efforts. So even we can write it here P. And below that this column we can even write, that is the descent of head, and that is at the level of 0. 0 means that the level of ischial spine the head comes, and even though after that the fetal completely expels out. And in medication and shared decision making, it again we can write the progression of labor and continuing monitoring of labor. So throughout this recording, if we found any deviation from the normal and that deviation is matches with the alert column, that shows the early warning sign. So these alert warnings should be recorded and should be highlighted by red pen and should be circled, and appropriate action should be taken off, and the seniors must be informed priorly, so they can be take care of these deviations and appropriate intervention could be planned off. So this is the basic aim behind this labor care guide. So here in this lecture we have covered all the aspect of the latest revised Partogram, that is labor care guide. Thank you.